One of the biggest unmet clinical needs in bladder cancer is salvage therapy for non-muscle invasive disease. This is second-line therapy after established therapies have failed. So our usual therapy for non-muscle invasive disease starts with low-risk tumors only getting a single dose of chemo at the time of bladder tumor resection. For intermediate risk disease, mostly the ones that recur, we will give chemotherapy or maybe BCG. For the high-risk disease, they definitely need BCG, and it's typically given over 3 years. Some will be called out and given immediate cystectomy. But what happens if the BCG fails? This is where we have a lack of options. On the one hand, we can do more intravesical therapy, and there are several options there, but they're generally not very effective. On the other hand, we can remove the bladder, which is definitive and will heal most patients, but a lot of patients are ineligible. Some will refuse surgery. It's associated with many complications, and there are clearly risks associated with this. So we're asking our patients to walk a tightrope between bladder preservation and removing the bladder, and what we really need are better bladder-preserving therapies in patients who fail BCG. So one of the important messages is that we need to optimize first-line therapies so that fewer patients need salvage therapy. This includes doing repeat bladder tumor resections for high-risk disease. We need good quality TURs in all patients. We need to be thinking about the prostate and the kidneys as alternative locations for disease. We need to give maintenance therapy when we're doing BCG and chemotherapy. We need to think about the timing of reassessment, and I'll show that in a subsequent slide. And as mentioned, we need to be thinking about immediate cystectomy for very high-risk tumors. So what about the urethra and the prostate? There was one study from Switzerland that showed that half of patients who have disease recurrence after BCG actually have tumor in the prostate or in the kidneys. And we need to be thinking about this when we're evaluating the patients. As for the timing, especially patients with carcinoma in situ, about 55% of them will clear disease after 3 months after just the induction BCG, but 84% will be cleared after the first round of maintenance. So we need to be waiting these 3 additional months, and we need to be evaluating the patients at 6 months before deeming treatment of failure if carcinoma in situ is still present. Immediate cystectomy needs to be done for high-grade T1 if there are other factors. For example, if it's a large tumor or if there are multiple tumors, if there's also carcinoma in situ present, we need to be thinking about it. If there's also lymphovascular invasion present, if it's extensive invasion of that first layer of the bladder wall and not just a small focus. There are rare subtypes of bladder cancer that need to be treated with cystectomy, even if it's only T1, if it's in a diverticulum. And if we are doing that standard re-resection and we find persistent disease, even though we think we got it all the first time, those patients are at high risk and should have a cystectomy. One of the most common options for salvage intravesical therapy in patients who don't get cystectomy is BCG and interferon. The problem is there's not really good evidence that it's any better than just an additional dose of BCG. You can see here on this slide some of the potential response rates. Only about a third of patients will remain free of disease. If the BCG was more than 12 months ago, patients will respond as well as if they'd never had BCG. And so in these patients, it really does make sense to do additional rounds of BCG. These results from a SWOG trial in the United States comparing gemcitabine, or just looking at gemcitabine as a salvage therapy, show what we can typically achieve with additional chemotherapy, which is only about a 28% recurrence-free survival at a year and 20% at 2 years. So the vast majority of patients with additional therapy will recur. We need to avoid multiple courses of repeat intravesical therapy. This is old data, but it shows that the response rate declines with each additional cycle, the rate of progression increases, and the rate of metastasis increases. So salvage therapy for non-muscle invasive bladder cancer is a big unmet need. To summarize, we need to optimize first-line therapy to reduce the risk for salvage. We need to look at salvage therapy as also risk-adapted as we do for first-line therapy. Highest risk patients get cystectomy. A second course of intravesical therapy is reasonable, but it should only be a second and not a third and a fourth for high-grade TA and carcinoma in situ. And for the recurrent low-grade tumors, we probably can do multiple courses without worrying too much about progression. The exciting thing is that there are a lot of new agents in clinical trials in this setting, and there are likely to be big advances in the coming years.